Session where we got a good perspective going, and I wanted to now introduce the panel that will be talking about the corporate perspective. To start with, we have Katie Forget. She's the Managing Director of Sanofi Espoir Foundation. Then following Katie will be Francois Bompard, the General Manager for Sanofi Aventis. And finally, Claire Hitchcock, who's the Director of Europe and International and Community Partnerships for GSK. So if you want to read more about their years of experience and expertise, their bios are in your little packet. So Katie, would you like to start, please?
Sure. So first of all, I want to thank very warmly all the teams who initiated this meeting, the PQMD teams, and as well as Tulip. I want also to introduce Catherine Boniface, who is working with me at the foundation, who is in charge of many medical programs, and in particular of coordination of vaccine and medicine donations. So we have chosen with Francois, my colleague from the Access to Medicine department, to speak together because we share the same and very complementary vision of CSR and access to care. Why? Because, as you know, and as David said before, healthcare is among the most universal rights and needs for humanity. And in fact, medicines and vaccine is very important, but it's just part of the answer. It's the reason why the foundation is working in close cooperation with the Access to Medicine department to address all the issue of the access to healthcare for the most needy population. So the foundation, let's say it's new. It's a sort of baby because it's born in October last year, but it's not new in a way because it has been built to capitalize all the, let's say, more than 15 years of programs and of expertise built on international partnerships. So our mission within the Sanofi Espoir Foundation is very clear and very optimistic, let's say, and passionate, is to try to contribute to reduce the healthcare inequality among the most needy population. And it's part, like the Access to Medicine department is part of the CSR agenda of Sanofi Aventis, and together, even if the foundation is a separate legal structure, as the Access to Medicine department, we belong to the CSR direction, corporate direction. So, of course, the CSR philosophy and vision is global, but it illustrates the way we want to act at the regional and local level. So it's very important in the region, and it's also a part of the pride, and it gives sense for employees, because the foundation in the three pillars of the foundation, I will explain which are these three pillars. There is also the involvement of the employee, and it's very important because it gives added sense of what we do every day within the company. So to try to contribute to reduce the healthcare inequality among the most needy, our two main mission is, first to respond and to coordinate the humanitarian emergency. Of course, in humanitarian emergency, access to healthcare is essential, like access to water, access to food, and a roof on the head. So we answer all the big humanitarian emergency, and we coordinate all the medicine and vaccine donation there. And the other pillar, very important of the foundation, is moreover the emergency situation, is to build very long-term partnership with all the stakeholders. I will explain which type of stakeholders to reduce the healthcare inequality in a more long-term agenda. So we are not in a philosophy of philanthropy. For us, philanthropy is more at the individual basis. We are in a partnership philosophy, which is more different. Perhaps, let's say that philanthropy is perhaps limited for us to medicine and vaccine donation, and even in emergency situation, we try with NGOs, and some are in the room, not only to provide aids in the emotional first period, but more in the post-emergency situation, because it's more important there. So in more long-term partnership, I will not have time to go in deeper in all the different programs, but we address, in fact, two main areas. The first one is to fight against diseases where Sanofi has expertise to bring, because as I said before, we are not in a donation, but more to share expertise and also human resources and finance, of course. So these diseases we try to find with many partners are non-communicable diseases, like we have a big program called My Child Matters to find childhood cancer in emerging and developing countries. It has been launched more than 5 years ago, and it's developing now. There is ongoing partnership in 19 different countries, in Asia, in Africa, in South America. We have also a program fighting diabetes, and other communicable diseases like tuberculosis, for example, in South Africa, in Asia, like in India, and neglected diseases like Buruli, ulcer, leishmaniasis, and other diseases. And another pillar of our long-term partnership, which is very important, to go through a development agenda, because health and development are very strictly linked in this type of emerging and more in developing countries, is to try to improve primary and healthcare, and to fight against children and mother mortality. So just to comment the way we act and what is in the DNA of our foundation is we address what we call the base of the pyramid, is the community first. The communities are at the needs of the communities are the main factors to drive the foundation programs. It's how we can provide partnership which address the unmet needs of communities. What type of support are we going to provide, with which type of partners? And we try to gather partners in a complementary way with NGOs, with hospitals, with healthcare professionals, and to address also the top of the pyramid, if I can say in that sense, is the priorities were at the base of the pyramid of some countries and healthcare authorities. We want to see at the end of the program, if there is a hand, because that's a long-term partnership, if these priorities are on the top or more on the top of their pie, let's say. So for that, it's not communication, it's action, and it's action with at the ground level, and it's also advocacy with all the partners and the NGOs for moving the lines. So these programs are based, as I said before, not on a donation spirit, but on partnerships. And these complementary partnerships, we try to provide not only financial support, but also expertise. When we act in an area which is very incoherent and very closed to your art of the business of your company, it's not the same thing if we have chosen to address cultural or environment issues, but to address healthcare issues, as it's very linked with our business, we can bring expertise and go very deeper in this program, much more than if we bring only financial support. What is key in this program is we are not in a charity spirit, we are in a building capacity spirit. It's to say that we are not in a substitution spirit, we are helping to build capacity. And at the end, we want to try to collaborate to a South-South agenda and dynamic. So this capacity building at the heart of this program is to address all the complementary... Oh, I will re-say the issue which are complementary to the access to medicine issues, which is more at the beginning of the story, which has to see with prevention, information, education, training, professional training, which is key in this part of the world, access to care, which type of innovative model you can bring with partners for access to care, for example, with microcredit, micro-insurance, and all this type. Which type of new technology you can bring, for example, for reinforcing prevention with early diagnosis, and all this type of innovative models. We are not in a donation spirit in the way that we want to measure the programs. Is to say when we enter in a partnership, it's a long-term way, more than the minimum is 3 years, but it's sometimes much more than 3 years. And the question is not to do, the main question is to know if you do well, and to try to measure the impact, the social and the economic impact of your programs. So we have tried to build with our partners criteria to measure these impacts, but we have a room of improvement to measure this impact, but it's key. It's key to, for many reasons, it's key to know if you have well done, it's key to see if there are important and impact of the direct beneficiary, the communities, the professional healthcare, the policies. It's key if you want to know when you can go out of this partnership and when it's sustainable. So it's key in each of our programs. So just key figures, but just key figures for last year's. So we are in partnership with 55 different partners across the world. It's more, as I said, emerging and developing countries. These long-term programs are developing in 50, 60 different countries. And you have also the figure for beneficiary in terms of prevention, education, and training. Just to summarize, so our Sanofi Espoir Foundation is based on 3 pillars. So the first one is to answer to humanitarian emergency. Excuse me. And the second one is supporting innovative development programs. And we try as much as possible to encourage involvement and mobilization of our collaborators within the Sanofi Aventus world for these 2 types of action. I just want to come back perhaps on humanitarian emergency and what is key message for me for vaccine and medicine donations. So just key figures for last year on what we have done in terms of humanitarian emergency. So the country where we have worked, the donation of boxes of medicine and doses of vaccines. As I don't know if it's David, I think we have underlined that there is no international criteria on how to evaluate this donation. So I put a figure for you, but it's just a figure as we don't communicate on the commercial value of this donation. We just communicate on the number of boxes or doses of vaccine we donate. That's all. And to go perhaps more on the role of the foundation when there is an emergency situation. So it's key to coordinate. It's key to coordinate inside the company and with the different partners outside, because there is an emotional period just after an emergency situation, in particular after a natural catastrophe. It's not the same for conflicts. And during this, let's say, emotional period, you have a lot of requests for donations from government, from different parts. And it's key not to do under the pressure, but to do in an efficient and professional way and to coordinate. So the role of the foundation in this case is to decide, depending on the country impacted, on the level of the catastrophe, on how we are going to provide our support, if it's donation of medicine and vaccine, if it's needed, and only it's needed, if it's financial support for, as I said before, post-emergency period, like Haiti. We are always, let's say, in post-emergency periods there. And if we call for employee mobilization and generosity, for example, for IT, we have called for employee mobilization around all the different affiliates in the world. So for that, we prepare a kit of communication on the situation, on what we are going to do, which NGOs or organizations we are going to work, in which part of IT we are going to work, and which type of project we are going to support, and all that. And after that, and only after that, we appeal for generosity on specific programs. And for example, for IT, there was 450,000 euros coming from the employees. So it's great, and it's on the DNA of our company. There is a sense of it's not just a chance. It's they are not only proud to do that, but it's normal for them. They are part of an healthcare company. It's part of our mission and role. So just I will perhaps conclude by two messages. For us, donation of vaccine and medicine are not sustainable. We are not in a substitution of healthcare system in the countries. So it's limited for emergency situation only. That's the first point, and it's key to coordinate. And thanks to organizations like TULIP in France, like PQMD, Partner in Health in the UK, even if there are room to improve, and I think that this kind of meeting is very important to share all together our ideas on this matter. They are doing a big job, and I think that it's key in the healthcare donation. Perhaps it's key for all the donation, but perhaps as it has been said before, as health is essential for human beings and it's a human right, it's key to act in a very responsible way, to be sure to answer to real needs. Evaluation of needs in that case is crucial, and to be sure that it's the vaccines or the medicine we are donating are appropriate, are well used, and match the needs at the end. Thanks a lot.
Francois, do you want to come up?
Thank you and good morning. So thank you to PQMD, to TULIP and all the other partners for giving me the opportunity of being with you this morning. Also for the unique opportunity of being for a few hours in the shoes of the general manager of Sanofi Aventis. I very much enjoyed that. I was amazed by the level of respect that some people seem to pay to me and to every single word I was saying. Now I understand better. So it's just a typo in the program. I'm not at all the general manager of Sanofi Aventis. I'm just the deputy head of the Access to Medicines department, as well as the medical director. I still hope that you'll listen to me with some interest. So Access to Medicines is one of the departments of Sanofi. It's one of many departments. We are part of the organization. We are a team of about 30 people. We also have 6 colleagues out there in the field in Africa working with us. And that went wrong. That's fine, sorry. Our mission is to focus on emerging and developing countries and to sustainably improve access to medicines for all patients, including the poorest patients, for a selected group of diseases in which we have developed an expertise. I'm going to explain a little bit in more detail what we mean by this. But it's important for us right from the beginning to say that in this endeavor we have 2 objectives. The first one is a corporate social responsibility objective of doing good for the community, help the countries go out of the vicious circle of disease and poverty. But we also have a very clear objective that we put at the very same level in terms of importance and also in terms of sincerity, which is an economic objective. We are clear that this is also part of the company's strategy to develop its presence in developing countries. So even though the idea for us is certainly not to make profit at present with the poorest patients, it's about developing our presence, and maybe sometime this will lead to economic opportunities, and we are working in countries which today are irrelevant for the business, but which tomorrow may become relevant. So it's important for us to say that right from the start. These are the 2 reasons why we are in this, and again, we are as sincere on both levels. So we work in 4 big domains. Traditionally, we've been focusing on infectious diseases, malaria, TB, sleeping sickness, and leishmaniasis. A lot of us come to some extent from the HIV/AIDS world. We know, all of us, how much the landscape has changed because, or thanks to, if I could use that word, the HIV/AIDS epidemic. But we're also now looking at chronic diseases. We really know that the big challenge for big pharmaceutical companies ahead of us is what do you do for people with diabetes, for cardiovascular disease that are just as prevalent and sometimes more prevalent in the developing world than in the developed world. We also know that we are going to be challenged sooner or later for access to innovation. Why do you not give access right away to your latest cancer drugs in the developing world? So we are looking at this through two diseases which are not neglected, but which are about neglected patients, which are epilepsy and mental health. These are terribly stigmatizing diseases in the developing world. They are just as prevalent over, in the south, as I could say, as they are in Europe or in North America, except that, as was the case 100 years ago here, these diseases go with lots of misconceptions. People are thought to be inhabited by the devil, to be cursed, and these people are cast away from society, and that's a terrible condition to be in, and nobody cares about it. And we are very proud to be pioneers in this field. And for us, it's a way to start testing economically sustainable models to provide access to patients who have lifelong diseases. It's one thing to give a treatment for malaria, which is a 3-day treatment. It's no big deal if your initiative stops after a few months or years. It's another story to put an epileptic patient or a schizophrenic patient on treatment. You cannot go away after a few years if your system doesn't work. So there is a serious responsibility on the part of the company to have there a sustainable way of providing drugs and access to care for these patients. So that's what I'm going to say about these diseases. Just to say that how we operate is to work with external stakeholders. Of course, we don't master all the skills. And we mobilize the skills of the company. The reason why I'm insisting on skills is because oftentimes people turn to us because they think we are rich. So, can you please give us money? We say we have better things to give to you than money. You need money, you turn to bankers, you turn to philanthropists, you turn to the Global Fund. If you need our skills, then we are interested in talking to you. I'm going to say a few words on what I mean by skills. The way we do it is, first of all, we improve our current drugs, and we also do research for new drugs. I'm going to show you what we've done in malaria. We make the medicines affordable through a tiered pricing policy. I'm going again to dwell on that a little bit more. We are very clear also that drugs alone are not enough, and we provide information and educational tools. And we use our industrial network in developed and developing countries. The history of the group is such that we have over 20 manufacturing plants for drugs in developing countries, in China, in India, in Brazil. So we are not just a big pharma in the sense that we are a developed world company. We are also a developing world company. We are a generic manufacturer. And we want to use that to the best of our extent for access to medicines. This is what I mean by know-how, by expertise. This is a series of things that the company does for a living. We are experts at developing drugs, at producing drugs, at marketing drugs. And marketing is not a bad word when it's used for good purposes. We also have presence in the field, and that makes an enormous difference. We have 1,000 colleagues in Africa, Sanofi Aventis colleagues, and these people can be mobilized to help our program. That makes a lot of difference. So these are the sort of skills that we put at the disposal of the community at large. Again, instead of our money, which is not our core business, providing money is not our core business, we can use these skills. And even though we are a small team of about 30 people, of course, we rely on the entire company to help us to put these skills to use for our programs. So let me take very quickly the example of malaria, maybe to be more concrete about what I mean. And as you know, malaria is a terrible scourge. About 300 million people come down with a malaria attack a year. About 1 million will die, primarily kids in Africa and also pregnant women. So this is a major disease. What we've done is, first of all, we have developed a simple drug. Here you have what we have developed. These are the old drugs. As you can see, an adult needed to take 8 pills a day, 4 in the morning, 4 in the evening. We have developed a very simple drug that is called ASAC, which enables kids to be treated with just 1 tablet a day up to 14 years of age, and then afterwards 2 tablets once a day. It's a small innovation. We are not going to get a Nobel Prize for this, but for people in the field, it's a tremendous innovation. It's a tremendous progress. The tablets also are soluble, which make them great to be given to little children who cannot swallow tablets. So first thing, we improve the medicines we have. Second thing, we make them affordable. And the idea there is the tiered pricing policy. In other words, it's the Robin Hood approach. The rich pay for the poor. So the very same drug is sold in public markets at what we call no profit, no loss prices. As you can see here, very low prices. And we sell exactly the same drug under a different brand name for a profit. There is profit for us, there is profit for the wholesaler, there is profit for the dispensing pharmacist. And the profits we make here enable us to go beyond what we could do if only we sold at cost. And so this is a model we believe in. That's the only way we can get out of the current situation as far as access to medicines and many other issues are concerned, is you have the rich who have got to pay for the poor. That's the model we believe in. Third thing, information educational tools. So we are very much aware, and especially when you talk about malaria, that drugs alone are not going to do it. You need to prevent malaria. You need to tell people who don't know that malaria comes from a mosquito. We've done a survey in Chad, and it was amazing that people who've been living for generations with malaria, some of them did not know that malaria came from mosquitoes. They thought it came from the sun, from the food. Why would you sleep at night under a bed net if you believe that malaria comes from food? So that's the first thing to do. Provide information on what you need to do to prevent the disease, how to diagnose it properly. Not every fever in Africa is malaria, and still millions of people get malaria drugs on a yearly basis for nothing, for a disease that is not malaria, and then, of course, treatment. So we believe a lot in the promotion of a comprehensive disease management, and that's because we have some expertise. Beyond the drugs, we know the disease, we know the experts who know all the aspects of prevention, diagnosis, and treatment. And so with them, we develop tools that are adapted to every layer, if I could say, of the healthcare pyramid. I wouldn't say at the bottom, but at the base, you have communities and families, and at the very top, you have the big teaching hospitals. And the further down you go, the healthcare pyramid, the less information is available. And so what we've done is for each of these layers, each of these constituencies, we have developed different tools. For experts, we have developed big textbooks. These textbooks won't help you treat a patient in the field, whereas a simple handbook like this will. We have developed lots of programs, and don't have any time to dwell on it, also for children and communities that are based on images, on pictures, because many people cannot read. And as an example of that, here is a picture that depicts an environment where mosquitoes can breed. This is a picture from Côte d'Ivoire. And here is exactly the same message that was adapted by people in Burkina Faso, that was mentioned earlier this morning, Burkina Faso. And it's exactly the same message, except that people wanted to redo the drawings, to have the houses look different, the dresses look different, because these pictures will speak to people in Burkina Faso, whereas this one will speak less. So it's just one small example of we provide the basic tools and people adapt them. And of course, we don't do ourselves all the job. We go through the legitimate actors. It's not up to Sanofi Aventis to go and teach to school kids what is malaria about. So we provide the tools to the health and the education ministries. We provide the tools to the teachers, and it's them, the legitimate actors, that do the job in a way that is adapted to their legitimacy. So here is the result of what we've done in malaria. These are the countries where ASAC, the drug I showed you earlier, is sold. We launched it in 2007, and we have to date delivered over 80 million treatments. 80 million treatments, 80 million attacks treated. It shows that this drug, together with this whole package, meets a demand. The drug is manufactured in Morocco because we believe in the importance of transferring knowledge and expertise in our developing countries' affiliates. And you can see here that the figures are going up very, very steadily, showing that this drug really meets a need, not only because it is cheap, but also because it's in a form that is adapted to people, and it comes with services that are derived from the expertise of the company. So very quickly to conclude, what is our raison d'être? What purpose do we serve in the group and in society at large? In the group, first thing, and that was mentioned earlier, the pharmaceutical industry has got a terrible image. We feel, because we are from the industry, that it's undeserved, but we know also that we are to blame largely for that. So things like access to medicines help, hopefully, to remedy that poor image, not only outside of the company, but also inside the company. It's very important for our colleagues to know that they work for a company that does this sort of thing. Second thing is access to decision makers. I'm very blunt with you here, but that's what we do is partly for that. It's part of the soft power of the company. And if I can take maybe a risky comparison, if you think about President Bush, George W. Bush, he certainly was a president who believed in asserting the power of the United States on the economic field, the military field, and so forth. So it's interesting to realize that this is also the man who created PEPFAR, the big program for HIV, also the President's Malaria Initiative, and that makes a lot of difference. So if a person like George Bush understood the power of what you could call health diplomacy, Access to medicines and the Fondation Sanofi Espoir, to a large extent, are part of the health diplomacy, the soft power of the company. It's the sort of thing that enables us to speak to decision makers on issues that are of common interest to them and us. Business opportunities, I've mentioned that. It's not today, it's maybe tomorrow, but that's important for us to justify what purpose we serve in a company like Sanofi. We need to tell our colleagues who are earning the money that we can use that we're also here for the long-term business health of the company. Impact on society, very important. I don't have time to tell you everything we do, but we measure the number of people we treat, the lives we saved. We work in sleeping sickness. Every single patient you treat is the life you saved. We have treated 150,000 people since we started a partnership with the World Health Organization in 2001. We have saved, and we can say that because we know that every patient treated is a life saved. We have saved 150,000 lives. That's important. Also, in terms of impact on society, it's the impact of the business we give to our plants in the developing world that produce these large volumes of drugs that are sold at very small profit, but which keep the business going and help transfer technology. Last thing, we are also, for the company, a source of innovation. Our operating model is based on partnerships, which is a bit of a novelty in big pharma. We work with lots of partners out there, NGOs, the Bill and Melinda Gates Foundations, the countries themselves, the ministries of health, and that's a sort of new way of operating for big pharma. We're also there, and Cathy has alluded to that, to test new business models for the base of the pyramid patients. Access to medicines, of course, access to drugs themselves, but also access to an integrated disease management, which goes way beyond just the provision of drugs and vaccines. So that's all I wanted to say, and I thank you for your attention.
It's still the morning, so I'm saying good morning, everybody, and thank you very much for inviting me to come and talk to you. I was really struck by the presentation from Sanofi because I think it really reinforces how much we are all united in the way that we want to support medicine donations and our philanthropy and our cash donations globally. And I think that I think I could say for GSK that there are a number of ways that you work and the best practice that you have that would be very similar for us. So what I'm going to do is really touch on some changes that are going on within GSK that are really informing the way that we work in developing countries. But before I do that, I'd just also like to say that I've been involved with PQMD for over 5 years now and was a former vice chair. And it has been a really important forum for me, both personally and professionally, in my career, because of the camaraderie and the collegiality that has really endured. And what I'm really struck by is that when I first joined PQMD, I was the only not English-speaking person, but only one who had an English accent. And I got a lot of indulgence because sometimes I could say really critical things and people would say, oh, Claire, she's so lovely. She's saying things that aren't very nice, but we like her anyway. Actually, that's not the case now because we've got lots of people from all over in Europe. And I just think that's great because it means that we're expanding our reach across other organisations. Anyway, that's just my personal thing. So, what I'm going to focus on is a speech that our Chief Executive, Andrew Whitty, made in 2009. And this was a real turning point, both internally and externally for GSK, where Andrew was really signifying to the outside world we were going to be a different kind of company and we were going to engage with society in a very different way. So, for example, changing our commercial model, so we are being more flexible on the pricing for the medicines that we sell in the least developed countries, that we are reducing prices for patented medicines, and that we would reinvest 20% of the profits we make in the least developed countries back into healthcare infrastructure. And underpinning all that, more collaboration and opportunities to work with others to fight the diseases of the developing world. And so we are moving from being a company that supplies drugs to a company that really is going to spend time and work with others in delivering solutions. And I've actually given this presentation internally, and one of the things I've said, and I'm kind of reluctant to say it, is that, you know, what we used to do, I mean, it's a bit like what we used to do was sell our drugs and have no interest, to a certain extent, in what happened afterwards. And this signifies something to say, no, actually, as a company, we are absolutely going to be concerned and care about the way our medicines are delivered. So access is really at the heart of this. Now, one of the projects that we're most known for is the elimination of lymphatic filariasis. And this was set up in the late 90s. Along with Merck and IMA and the World Health Organization. This is a really good example of a public-private partnership. And GSK provides albendazole for this program in over 80 countries. And we have produced billions of albendazole tablets that are donated. And these tablets are manufactured in special sites in South Africa and also in India. So this is a long-term commitment. We're making great progress in the elimination of this really horrible, debilitating disease. But what we've learned from that is that there's a lot more that we can do. So the partnerships that we develop with the governments have helped us to forge other relationships and have different conversations about procurement of medicine. But it's also challenged us as well to work in a more integrated way with other neglected diseases. So the World Health Organization asked us to increase our supply of albendazole to support deworming in all schools in Africa. So from 2012 onwards, GSK will also be supplying albendazole that will be used for deworming school children in Africa. And we've actually got some very exciting plans to make sure that that's integrated with school health and nutrition, personal hygiene, and really putting children at the centre of this, but also working with a wide range of other organisations, not just governments, but NGOs that are working in this arena. So as the lymphatic filariasis programme has developed, we've been challenged by others to do more. And another way of doing more is the setting up of a new unit within GSK called DCMA, and that stands for Developing Countries and Market Access. I'm really proud because our global head of communications, Duncan Learmouth, moved from that role to head up this new unit. So he's actually bringing some very good commercial experience, but also some very good communications experience to this unit, particularly in external relations. And I've heard him say on a number of occasions that, he has very high hopes for this unit, but he is determined to turn the business model on its head. So he says, what we want to do is we want to sell 1 million units of a medicine and still make the same profit as we might make selling 10,000 units. I hope I've got that number right. But also, in terms of to reinforce that whole notion of increasing volume, he has incentivized his general managers that their bonus is based on volume, not the profit sales. So, this is challenging our colleagues in a very unique way. but also really giving them some impetus to think through and to work with others on access, and in particular how that might be supported through improving healthcare infrastructure. So that's a very strong commercial approach, and it's pretty hard-nosed. And I think for us, for some of my colleagues, it's going to be pretty tough. But we're also saying that to support this, that we, through the team that I work in community partnerships, is to, I suppose, to help facilitate some of those relationships. So another thing that I've been working on, and I mentioned it earlier, is the reinvestment of 20% of the profits that we make in the least developed countries. And I've been really fortunate to be leading on this because, as you'll appreciate, the profits that we make in those countries, and of the 49 countries that are on the index, we actually make profits in 33 of those. And they do range from, say, £1,000 to £1 million that we have for investments in Bangladesh. So it's important to us that that funding is reinvested in a very careful and appropriate way. So we've asked Save the Children, Care International and AMREF, the African Medical Research Foundation, to join with us in a partnership where we will be channeling those funds back into those countries. And the funding that gets reinvested is proportional to those profits made. And the reason why we're working with those organisations is because they have such a strong presence in those countries and some very good existing programmes. So actually we get the benefit of the presence and the expertise of those organisations in those countries. And so we've been spending a lot of time and lots of discussion to agree how we're going to work together, because this is a very unique partnership. And we've decided that we're going to focus very clearly on building the capacity and capability of community healthcare workers. We came to this conclusion following a workshop that brought in a lot of experts, and this was something that really came to the surface, that amongst all the participants, that this is a very neglected area. And for GSK, we acknowledge that it's really important to have people working at the community level who do have experience of administering vaccines. I know that's a very specialist thing, but also to administer and prescribe, very simple antibiotics and even over-the-counter drugs. So we've got new programs being set up. One is in Sierra Leone, which is very exciting, where we're working with Save the Children and UNICEF. In fact, what we're putting in, GSK is putting in £20,000 for a £500,000 program that is really supporting advocacy in Sierra Leone so that the government really understands and can see the benefits of community health workers, because it is an area that's not recognised in Sierra Leone, so that's quite a political area. And then at the other end, in Bangladesh, we're working on another really exciting programme with an organisation called Friendship that has a floating ship, and this ship goes to the most remote areas in Bangladesh, in the chores, which are sometimes flooded and sometimes not. And using mobile technology, training community health workers to be able to key in symptoms of patients that then gets transmitted back to a terminal on the hospital, so that the volunteer doctors are able to understand the diagnosis and then make a prescription for the medicine. But again, what's so incredible about this is that the technology is really being embraced by illiterate and innumerate people. And I have to say, I'm still flabbergasted to know, seeing this woman, she can key in all these things in her mobile phone, which collects all the information about the patients, where they live, what's wrong with them. And, it's absolutely transformed her life. She can't do texting like we would do, but she knows what to fill in. So what is so exciting also about having this funding available through the 20% reinvestment initiatives is means that we can really focus on innovation and doing things that are different and challenging. So where does that leave us if I'm saying that we're doing things differently now? So we're having different kinds of relationships with our NGOs. And I know this is a picture with Americas and Project Hope and Direct Relief and IMA and Matt, please pretend you're there. I feel I have to give you a name check because you are our really valued partners in emergency response and humanitarian relief. And we're not going to change that. We have a very unique approach in our medicine donations whereby those organisations that I've just mentioned are able to select GSK medicine from inventory and have that in their warehouses ready for immediate release. And I'm really proud that GSK medicines through this process are some of the first to arrive in emergency situations. But the discussions I think that we'll be starting to develop with our partners is you're the experts in reaching the unreached. What can we do more? How can we work more closely together to really drive the access agenda? And I'm conscious that that's, over the years, that those are some of the conversations that we need to be having with this, with the membership of PQMD, because certainly all the NGOs, but certainly all the companies, you're hearing a very resounding, we are concerned and committed to access and improving infrastructure. And, the organisations here are the agencies that are excellent at doing that, and the way in which you work with partners on the ground. So there's a bit of a challenge here, I think I'm laying out, which is how do we really kind of ratchet up our relationships? They'll go beyond cash donations, medicine donations, but they may even verge into some commercial relationships as well. And I think we should be open to that, because I think all the companies here, certainly all the companies here, are thinking very carefully about pricing, what that means, but also what that means in terms of our reputation as an industry and the way in which we really are going to improve people's health. So, as ever, there was so much, always so much that I want to say, because there's a lot of exciting things happening, across your organisations, but also within GSK. And this picture for me kind of represents, our very strong history in community involvement in health and education. But also, that we're going to have a really exciting future that is really going to be melding our philanthropic approach with improving, some of our commercial performance as well. So, thank you.
Thanks, Claire. Okay, I'd like to start with the first question while you all are thinking of some really tough questions for our panel here. And this is not a commercial, but Kurt Whedon had presented at our fall forum that J&J and BD hosted in New Brunswick, New Jersey. And in his new book, this just came out, he has a chapter which focuses on product donations. And he mentions a self-administered product giving checkup. So I feel like that's what the three of you have helped us to do this morning, is kind of give ourselves a checkup and learn from their expertise. But I do have a question for the panel here around, are there, because Francois, you had mentioned kind of the reputation that pharmaceutical companies have. Are there any negative PR ramifications to a product gift, or how do you ensure that product donations won't erode your commercial market? So I don't know if there's anything that either three of you could share about that and how you, work that into your roles.
if I can start, in fact, maybe I should let a lady speak first. Sorry. No, I mean, I think Cathy said it very well. For us, product donations are legitimate in emergency situations, and that's it. So there is no issue. You know, we don't. It doesn't matter if it hits our profits or anything. But the product donations are limited to these situations.
Yes, not only is limited to emergency situation, but to be sure that we donate in the right sense, we have rules of ethics in intern. We have set up a charter of donation, and we follow and we are compliant with the rules of WHO. So there is no overlap with the market commercial issues.
I would agree with my colleagues. We do donate medicines for community healthcare in very remote and impoverished communities. And by working very closely with our partners, they're able to indicate to us and show us that these medicines are reaching people who have no access at all and who really are in the greatest need.
And the other point, just to add, is that we answer to needs. We are not offering drugs, but we answer to needs, evaluation of needs coming from the ground, from the NGOs, the hospital, from in the emergency situation. That's the key things, I think.
Does anybody have any questions? Yes, Marlon.
It's just a congratulations, really. I was delighted to hear about your intention to donate enough albendazole to deworm all the school children in Africa. That's quite a commitment you've made there. So it's just I was also really pleased to hear you're not doing this just through governments, because we know the problems that can evolve there. Just last week we saw that the government in Kenya had suspended all its distribution of albendazole school children because it lost a big grant from DFID because of corruption. So it's great that you've included the NGO community there. But one question on that, do you also include the kind of ancillary support that goes with the donations of albendazole? One of the things we find in World Vision, we distribute around 30 million albendazole every year in Africa, just in Africa. We find that our biggest cost is not just the purchase of the drug, but also the distribution costs, the training costs for the teachers, all that kind of thing, which is, which amounts to much more, of course, than the purchase price of the drug. So does your program include those things?
Yes, it does. And I'm sitting here on behalf of GSK, and I've got my two colleagues in the audience, and I do feel really honoured because working for a company that is really at the forefront of these issues in responding to requests. And I think with the expansion of the albendazole donation, we have committed that we will ensure that there are some infrastructure costs associated with that, but it is going to be run in a similar way to the LF programme, whereby the country will have to apply for the product, but then show the plan, their country distribution plan, and that's where the NGOs and others will need to come in, and there will be some supporting grants to do that. We also have a programme called PHASE, which stands for Personal Hygiene and Sanitation Education, and that is going to be an integral component of the school's programme to improve children's understanding of hand washing, personal health, and say the school health and nutrition. And that's going to be over the longer term. But what we've been able to do is to bring together, I suppose, two areas of work that have been separate over the past few years and integrate them. So that's really exciting.
Veronica?
Sorry, just to elaborate very quickly on the point you raised, there are indeed situations where we need to provide beyond the drugs everything that goes with them. I didn't want to confuse you by talking too much about the program we have on sleeping sickness, the tsetse fly disease, but that's a situation where you have very expensive drugs. You have people who are in the most remote places you can think of. You have drugs that are very complex to administer. They need to be given by infusions. You're talking about giving dozens of infusions to someone in a very remote place. So in this situation, yes, we do have a donation program. We donate the drugs, plus we donate all the money that is needed to test people, to diagnose people, to convey the drugs, to give the infusion drips and so forth. So, we are not dogmatic, I would say. There are situations where we can be flexible, and the sleeping sickness situation is one where we are flexible. We donate the drug, even though this is not our sort of mantra, I would say. We donate the drug because that's the only solution for people to have access to the drugs, and beyond the drugs, we provide everything else. We pay for everything else.
Thank you. I think, Veronica, you had a question? Madeline? Oh, Jess. Sorry.
Thank you all for your presentations. They were lovely. One of the things that I know PQMD is wrestling with is this notion of improved health outcomes in terms of its work and its mission, and providing thought leadership in that arena of health outcomes. I'm wondering, from a corporate perspective, looking at the notion of monitoring and evaluation, a term that's often overused, but as you think of improving health outcomes in the work that you do and the medicines that you provide, the volunteers that you provide, what challenges, if you could speak a little bit more about what challenges from a corporate perspective are ahead of you as you look, sorry, I'm seeing the faces there, as you, what challenges are, probably at the forefront of many of the programs that you are rolling out? I mean, what should PQMD be thinking about in terms of its role, in terms of how improving health outcomes?
I love the way I get this. Because it's, and as everyone knows me, monitoring and evaluation is my favourite subject. And it is very, it's Vera's life work. I think you're right to raise it. In the 20% reinvestment program, I have to say one of the things that we've really been challenged on by our partners is, well, what is success and how are we going to measure success? And partly I push it back on them and say, well, what do you think success is, and what mechanisms have you got in place to identify those? That is a bit of a cop-out answer, to be honest. But I think we probably, as companies, we do need to get better articulating what those, what success looks like and what the health outcomes should be. Because, as David showed us earlier, we're really good at acknowledging and articulating what the inputs are, and it is much harder to do the outputs. So I don't really have an answer to that. I think possibly what we need to do more of is to make sure that there's more resource available from monitoring and evaluation, and to get that done professionally. And I know that, again, with very limited budgets, that's always the first thing that goes off. So I think, how do we work more closely with experts, with academic institutions, on a pro bono basis possibly? That would be a dream. But also, I think we've got to develop the business case to have to have more improved data.
Just perhaps to add to what Claire has said, let's say perhaps it's more easier in long-term programs, because when we decided with partners to set up a long-term partnership to fight against, for example, children and mother mortality, at the beginning we tried to imagine the criteria we are going to follow to measure the impact on direct beneficiary, on the policy, healthcare, etc., etc. So, in a regular basis, we try to monitor the social impact, the economic impacts. even if we have room to improve. But in emergency situation, for example, where we donate vaccine and medicine donation, it's much more difficult to measure. For example, even we try to know how many people have been reached by these donations. It's very difficult, for example. I know that some of our partners are in the room, like Amy or Alima, and for example, beyond the medicine and vaccine donation in emergency situation, we provide financial support for post-emergency situation. So for post-emergency situation, we try to monitor the impact of the financial resources we have bring, but it's key. Your question is key, and we have room to improve altogether. What is the I don't know if there is a unique model. There are many different models, like the London London, I don't know, business model, and there is a return on investment model. For example, there are different international models. We are looking perhaps to tailor, to have tailored model, because it's not unique model. It's to be adapted to the different situation, but it's key to measure the impact, perhaps more in long-term programs. It's for me, I think that it's easier, like and not in emergency situation.
Thank you. Very quickly, if I can try the two big challenges. The first one, I think, is oftentimes we don't take the time and don't want to invest the money to make the baseline evaluation. To measure, the impact, you need to measure the baseline. Oftentimes, people are so impatient to act that they just want to rush there and do something. And it's hard to convince people that you want to take, say, a couple of years and then spend $2 million to make a baseline assessment before you start acting. So that's the big issue. The other one is oftentimes when we have a program, we are not the only ones. There is a variety of actors. So then it's difficult to dissect what is due to your own intervention versus that of the other partners. So I don't know if that helps, but these are the two ideas that come to mind.
And for example, for programs which are above 200,000 euro, I think that in the future we have decided to reserve a part of the budget we give to the partners till the beginning to evaluate the programs.
Yes, congratulations for your presentation, but I have two questions, one for you, Claire, and one for you, François. Claire, you start your presentation explaining us the vision of Andrew Whitty. And on your slide, it was flexible on intellectual property. Can you a bit clarify? Because we know that in pharmaceutical industry is so important. And my second question for you, François, fantastic example about malaria, and that you has been done with the NDI. And can you clarify too, what is for you public market and private market? It's at country level, or can you explain after? Thank you.
The approach on intellectual property, I think really it has evolved over the years, and I may ask one of my colleagues to help out here if I don't get it right. But my understanding is, and so this is quite, this is a really big deal for us, was really looking at how we might be able to bring others into the, to work with us on the patent pool. So we have a research and development centre in Tres Cantos, and we've got an open invitation for others to work with us on key compounds. And I have to say that's been quite slow to come to fruition, but it's now ramping up. And we've actually been using our colleagues in the business units and in country to help stimulate that. So I think that it's an ideology to think more creatively and innovatively around intellectual property. And then I think the other thing is that we've also got much more involved in I suppose, strategic alliances and actually bought other businesses as well with generic products. So we also have a business, for example, in sub-Saharan Africa that has many, many products, including patented and generics. So what I'd say it's an evolving area. It is very, I think it is probably quite ideological in what we want to do. So we want to protect patent, but equally want to open some of those opportunities up to others who are working in the same area.
Thank you. So to clarify what we mean by public and private market, I would say the private market is our usual sort of standard pharmaceutical business. It's the for-profit pharmacists, chemists, drug dispensers. The public market is the market of non-for-profit organizations such as governments. Governments don't distribute drugs to make a profit, and also NGOs. So we work through three primary channels. The normal one, the classical one, I would say, is the private pharmacies that are in this for the profit. And the problem with these pharmacies is that they usually don't go beyond, let's say, medium-sized cities. They don't go in villages. There is not enough money to be made, and so forth. The governments go beyond the big cities with their health clinics, their community centers, and then oftentimes NGOs go even further out in the field. So the private sector for us is the for-profit sector, where the pharmacy is going to make a profit, and the public is governments and NGOs.
Okay, but that means that finally, in a big city, you can find the both presentation.
Yes, absolutely. And what makes the difference is that rich people are going to go to the pharmacist. They don't want to stand in line and being treated like dirt at a public clinic, whereas the poor people don't have a choice. So that's how the two markets are kept separate, also because there are different brand names. So to try and avoid traffics, having the non-for-profit drug be sold for a profit, it's got a different brand name. But it's for us, in Europe here, it's a funny idea because everyone, whatever their income level, goes to the same places to get their drugs. In developing countries, as you know, not people go to different places depending on their income level to get treated.
Okay, I think it's time. Oh, there's one more question. Go ahead.
Thank you very much for invitation and the interesting informations. I started a personal project since 8 years ago in Nepal, in Asia. And first I had one foster child. Now I have in a circle of friends 200, and we are supporting 3 schools and a hospital, and it's grown up. And my question is, now it is the time for me that I feel a limit, and I don't want to look to the limit. I want to go on with possibilities. And my question is, do or will very small NGOs get the opportunity to be involved into your programs, or is there a limit?
So I will start. No, there is not a limit of size of NGOs. The limit is, as I said, the health needs there are many health needs. So if we want to be efficient, we have to select. So we have selected different areas, as I said before, linked with the Sanofi expertise, or for example, we are also very much involved in fighting child and mother mortality. So if your project addresses one of the issues, it's not a matter of size of the NGOs. For example, you are speaking about Nepal. We are working in Nepal in close partnership with partners like Médecins du Monde, but Médecins du Monde works in Nepal with many local little partners. It's the way we want to work, is to say that it's not substitution, it's building capacity of local partners. So sometimes we said we are working with Médecins du Monde or with other partners, but in fact we are working in partnerships which much more than one big partners, because we are working with many little partners It's not a question of size, it's a question of expertise. And these little partners, they know very much the situation, the communities, they are key for the project. And they are key for the sustainability of the project.
Thank you so much.
Okay, a couple things before we go to lunch. First, let's thank our panel here. I just want to make sure that everybody knows that they will be here for lunch at least. So if we have any other questions on their expertise and maybe finding out how you can do your own checkup and benchmarking with these experts, please ask them questions. We also have gifts for each of the speakers and also for the panelists this morning. So please, I don't know if we're going to hand those out. Madeline's going to hand those to you. Lunch starts at 12:45 at the club, which is to the left of the room here, and then we will be back here at 2 o'clock. So thank you very much.